So today I'm going to discuss with you stroke awareness and prevention. Since I currently work at Aurora Healthcare System, this was a PowerPoint. One of my collaborating physicians is the stroke director there, and we put together a little bit of a slideshow that we had in our department, and here we go. So slide awareness, stroke awareness still remains the world's number 2 cause of death and leading cause of disability. That's number 2 in the world, 5th in the U.S., 3rd in the state of Wisconsin. Suffering a stroke every 40 seconds in the U.S., 23 people every 15 minutes. It kills 130,000 per year in Americans. That's 1 in every 18 deaths. I bring these facts to you only because I need you to emphasize that we think some of this is preventable, and I'll emphasize that in a few minutes when I talk to you on my further in the PowerPoint. So every 4 minutes someone dies of a stroke. Every year more than 800, almost 800,000 have a stroke, and 610 it's first or new, 1 in 4 are recurrent. Within 5 years, the risk of another stroke can increase more than 40%, leading cause of adult disability, and there are over 7 million stroke survivors in the U.S. So it is believed that 80% of strokes are preventable, believe it or not, and I read that and read it again. Looking at some new guidelines, they still have stuck with that. Fasting, F-A-S-T, is the key. It's a $75 billion per year estimated loss in healthcare dollars. Some of our famous stroke survivors, which some are still living and some are now passed away since this slide was introduced. And what is a stroke? We all know it's a sudden brain damage caused by lack of blood flow to the brain. Period. Lack of blood flow. What it causes it is different. Some are ischemic, some are embolic. A blood clot or plaque from somewhere else in the body becomes lodged. That's a picture of this one, of a diagram where the embolus got in the blood vessel, thrombotic. Symptoms persist or worsen over time, and time is critical. So there is a diagram of a stroke in the right side and the left side being affected. And what do we mean with the left side being affected? Face, arm, speech, time, fast. So here's another diagram of an ischemic stroke and what we might see on imaging because of this embolic event causing the ischemia to occur. So think about all those brain cells lost, okay, and the shift. So that little thing causes that much trouble. Isn't that amazing? Hemorrhagic stroke, bleeding around or into the brain, can be caused by different trauma medication, hypertension. So back in the day before we had all these great hypertensives, people would die, cerebrovascular accidents, hemorrhagic stroke, bam, hit the floor. My grandpa was one of those, 64, came home for lunch, had a sandwich, had something to drink, went back in the chair, and was gone. That was it. Hypertensive, but had very high blood pressure back to 66, I believe, 1956. So hemorrhagic strokes are a neurosurgical emergency, okay? So that is, boom, lickety-split. Hemorrhagic stroke, the rupture of the blood, they need to get that out of there. TIAs are more, I would say, maybe underdiagnosed, more common than we think, maybe, often called mini strokes. I think a lot of people don't even come in for these probably. Symptoms are the same, but they usually resolve in a couple minutes to hours. Patient told me, my grandma, I'd walk along with her, she always would fall on the sidewalk. You got to wonder, were those mini strokes back in the day? I asked her stroke risk history, I'm not sure, but then the grandma ended up with a vascular dementia, so you gotta wonder. Is it important to seek immediate It is important if you're suspecting a TIA. And you know, it gets hard because patients hate to come in, and then they hate to be second guessed, and why did you come again? And especially my patients with complicated migraines that look like stroke symptoms. I have a few of those, and they think their headache is different this time, and then they're told, no, it's your headache. Better safe than sorry, but you know what ends up happening is just like chest pain. You come in with the stroke symptoms, you come in with the chest pain, you get the bazillion-dollar workup, because what if it is this time? So more than 2/3 of the U.S. population cannot recognize more than one stroke warning. Do you and your friends know them? Or your family? Sudden onset of weakness, sudden severe headache, neck pain, loss of speech, vision, dizzy, imbalance, change in behavior, and all those things, facial droop. But listen, we also see those in a lot of other neurological sequelae. That's why sometimes patients come in. But, you know, we now have in place stroke protocols, stroke alerts, stroke teams. So if it is an ensuing stroke, we try to save brain cells. So what is a symptom of a stroke? So this would be for the diagnostician or the hospitalist or the NP working in an ER. What would you see in a patient who presents? They might have any one of these symptoms, and that would be the part of the brain. And obviously they're getting imaging, right? Or if they've hit their head, they're going to be checked out. Or if they have hypertension. So I won't read this to you, but those are the areas or the parts of the brain. And I know that the NPs in our hospital where I'm working, we have a stroke team. We're, you know, recognized and certified and all that. So they're trained in all this. Not all institutions are. So I'm sorry that this is a little bit blurry, but I just wanted to show you, although I was listing it here as like the structures and where it points to. So we're, you know, any part of the brain in the vasculature, we're at risk for these areas being compromised and leading to deficits permanent. And the goal is if we see the symptoms, we get them to the hospital, we act fast. Each identification is key. Early identification is key. The medical response and know how to page a stroke alert. It's like a heart attack, it's a brain attack. So if you show up in the ER, or your patient shows up, or you're on call and you're covering, labs will be done. There are nurses that do stroke scales that are part of this NIHSS. CT will be done right away. Nurses do an aphasia screen. They got to stay NPO. There's an order subset, and these are places that are fortunate enough to have ED stroke alerts built in and stroke protocols. And we are fortunate enough to live in a state that has pretty good, I feel. We have major institutions pretty close to us within 30-mile radius that could handle a stroke for us or anyone we care about. So if you're asked to call an emergency, and all day long where I work, we're having strokes from the ER to the room, you know, inpatient side, especially staff. We have our intensivists, we have our hospitalists to direct the team. And sometimes our hospitalist is an NP or a PA. They're drawing labs, they're paging me, they're calling me. Is this the patient's presentation? Have they had this before? So every time why are we in such a hurry? 32,000 brain cells just died with each second. In 59 seconds, an ischemic stroke will have killed almost 2 million brain cells. I know that seems incredible, but it's what happens. The gold standard is TPA now, as we all know, or we should know, given within 3 hours. Now, door to needle time, having my office next to the stroke, it went from 1 hour, 30 minutes. Okay? They get in there. They get worked up. They get diagnosed. The stroke alert is called. The sooner the better. One doctor just thinks he's hot stuff because I think it was 30 or 45 minutes he had the whole shebang done. So we could only be that fortunate, but it spares brain damage, loss of cells. So before treatment with TPA, and then after. Okay, so you see the blood flow because the ischemia is happening. So what are they? Why can we prevent them? Our non-modifiable risk factors are pretty obvious for us nurses and nurse practitioner students. Older than 55, African American, Hispanic have higher stroke risk. Hereditary, do we have a family member with a stroke? My father had his first stroke at 55. Okay? He lived to be 83, but he did something about his other risk factors. He couldn't change his age. He couldn't change his family history now. Males greater than 65 and women have a higher incidence. Personal history of stroke or TIA.
So for these students with, family nurse practitioners,
Yeah.
they need to focus on prevention.
I would emphasize prevention for us, and then you know what you might get? You might get the lady or gentleman that's had the TIA. They call, and now with the My charts and My Auroras and the My chart, I have people who type notes to me, and when you're in a clinic setting, you're seeing the patient, you get your messages after clinic or in the middle. iPad. They are describing this, and they think that we're just like on this. So a patient wrote, and they were having a heart attack, not to me, but my NP colleague in cardiology. They just don't want to come in and bother, especially the older folks that don't want to bother anyone. Modifiable, obviously hypertension, irregular heartbeat, diabetes, high cholesterol. I think these are pretty self-explanatory. Lack of exercise, in salt intake. So we've got to just be emphasizing those modifiable risk factors, and we can all talk a blue streak and get in people's faces and the sleep apneas and the obesity and all of it, but all we can do is document we've educated them and did the best we can and do the best for ourselves. I mean, we're not perfect either. So what can we do? We have the patient know their numbers, and I love the patient who has their little card and they know their blood pressure. You show them their cholesterol, and I print it out over time, and I show them, this is what you were, this is what you are, this is how we should be. And I talk to them about their diet and exercise, and sometimes I'm like, are you having trouble getting jump-started? Everybody I see, sorry to say, is deconditioned, most of my folks, because they're apprentice. If they need help getting into reconditioning, I send them to PT to get them going. We have a big cardiac rehab. I think it's really underutilized because it's all for people who've already had MIs, not for people we're trying to prevent MIs or strokes in. Manage. One of our colleagues was mentioning how her brother-in-law, recent MI, he's the youngest guy in cardiac rehab at 56. But at least he's in cardiac rehab because another colleague of mine's husband didn't make it this summer, 56. Yeah. Manage your health issues, diabetes, which puts us at risk, high blood pressure, high cholesterol, AFib, as you know, AFib, DFib, see your doctor regularly, don't drink too much, don't use illegal drugs, and quit smoking. And we can talk to our patients about all this stuff, which has been pretty obvious. It's pretty obvious, but we think they know. Do they know? Do they want to know? That's another question. So what are the myths and realities about stroke? The myth is it's not preventable, but up to 80% are preventable. Can't be treated. They require emergency treatment. That's why people feel that you shouldn't come in. Only happens to the elderly and one. Think about the young woman you may have had, or I have had one young woman, 27, with an AVM, atrial venous malformation, delivered her young child, it ruptured, and she was a stroke victim on my unit, 27. The person who took birth control pills that shouldn't have been and had a stroke that ensued, was prescribed, or that's why we don't prescribe them to smokers and all these other things. So they have happened. I think the youngest patient I had with a stroke in my career was 15. So things do happen sometimes. Stroke recovery, now in the days gone by, it was, 6 months and that's how you're going to be. Now they believe it can last a lifetime. So it was 6 months, then it was a year, then it was 2 years, then it was 5 years, and now the latest research says a lifetime. So if we get rid of some of those modifiable risk factors and try to do a better job, maybe we can improve the quality of life and the mortality. Be stroke smart, reduce the risk, know the symptoms, and have them call 911. You know, unfortunately, I think there's probably always going to be that one that's going to call it all the time, but they call it all the time. So it's an emergency in the community. We dial the number. We be smart about it. Why do we not respond to symptoms? Why do patients wait? They don't know the symptoms. They deny it's happening. They think nothing can be done, and you know what's sad but true? They worry about how much is this going to cost me if it's not. Or it's just the same thing, or you know what I'm saying. I'm tired, I'll go to bed and I'll be okay. Think the symptoms will be gone. They fear or don't trust doctors or hospitals. They like nurse practitioners to that. I'm kidding. So these were some references at the end, and I thank you for your time and attention regarding stroke. Thank you.